Thank you. Thank you for a very kind introduction at the outset. I must congratulate Diabetic India team, Bansi, Manoj, Rajiv, and the entire team for a wonderful academic session that they have dished out to the delegates. Thanks to their hospitality. The topic given to me is the place of other oral anti-diabetic agents in the era of SGLT2. Which, when, and why? See, today SGLT2, if you see that this is the 2022 ADA guidelines. If you look at the first column, there is no pointer here. The first column, that if you have an associated or ASCVD high-risk patient, what is recommended is after metformin start an SGLT2 or a GLP-1. That is what all the current recommendation is. So in short, ADA has tried to make it as simple as possible, and they say independent of baseline A1C, whatever the A1C, the use of metformin, people need to be on a SGLT2 inhibitor or a GLP-1 receptor. So that is where SGLT2 is today. And why is so? Look at the EMPIRE-X study. 33% relative risk reduction in cardiovascular death. And if you look at SGLT2 across the board, it reduces atherosclerotic events in secondary prevention cohorts, but not in primary prevention. Mark this. But if you look at the second message, across the board for all the SGLT2 inhibitors, unlike MACE, heart failure and cardiovascular death reduction is observed in both primary and secondary prevention cohorts. So that is where SGLT2 is today. Now look, coming back to this, we looked at if you have an atherosclerotic cardiovascular disease, SGLT2 comes up right on the top. So today SGLT2 has become the molecule, and becoming generic, it has become cheap, affordable. We can give it to every patient of ours. So that's why this topic, that what else can you give with an SGLT2? The main stumbling block is hypoglycemia. So you should minimize the risk of hypoglycemia, and here there are only two molecules which will cause hypoglycemia: sulfonylurea and insulin. If you don't use them, then you are on very safe ground as far as hypoglycemia is concerned. There is no problem. Next, if you see, you don't want to have a weight gain. Which are the drugs that will cause weight gain? There are three: the sulfonylurea, the glitazones, and insulin. These are only three drugs which will cause weight gain. So if you don't use them, you are safe. But as far as glitazones are concerned, the weight gain is not a pathological weight. It is a cosmetic weight gain. Because what the glitazones do is, it reduces the visceral fat and increases the subcutaneous fat, and it has got a very good effect on cardiovascular outcome. Now the next, if you consider what they say is, if cost is a factor, then after metformin, use sulfonylurea and a glitazone. Now India is a poor country. Only 2% of Indians pay income tax. Only 2%. And how many can afford the fancy prices? So sulfonylurea, metformin. But today the scenes have changed. Now cost too is no longer a limitation for DPP-4 and SGLT2. So today we have 9 therapeutic classes of hypoglycemic agents. You have 7 oral. And if you see the last one, 7, oral semaglutide, very expensive. It costs 10,000 to 12,000 rupees a month for the patient. Forget that. But rest of them are all within the reach of the common man. And I think this today, in the last 6 months, things have so changed on the diabetic scenario for the doctors and for the patient. It's a win-win situation. Cost is not an issue, and you have all the molecules that you have which you can use. But what is the current reality of diabetes? Look at this. This is in India now today. A 30-year-old man will live up to 75. That's the statistics. But if you have this same 30-year-old guy who becomes a diabetic at 30, he stands to lose 14.5 years of his life. So when you're treating a diabetic, this is what you have to keep in mind, that you're not treating diabetes to control his sugar. You are treating him holistically so that he has a nice, healthy, long life, and that 14.5 years which he stands to lose, you can save for him. That should be your attempt. So what do patients really die of? 80% will die of a cardiovascular problem, macrovascular disease, renal failure. You go to any dialysis unit, 60% of the patients there are diabetics. And now we have another big epidemic on hand, which is just the tip of the iceberg at the moment because we are not looking into it. You do a sonography for any diabetic patient and you will see that they have got fatty liver. So this is the other epidemic that is coming. And this fatty liver is driven by insulin resistance. The UK PDS study was a brilliant study done on newly diagnosed diabetic. And what they showed was that by bringing down the HbA1c to 7, you could have very nice benefits. So look at this. This is the ADA ESD guideline of 2006. What does it say? Diagnosis, lifestyle modification, metformin. If HbA1c is more than 7, treat. If HbA1c is less than 7, no treatment. This is what was in 2006. So then came major studies that let's see if we can reduce the HbA1c to below 7 and give benefits. So there were 3 major studies done, Accord, Advance, VADT, to get the HbA1c below 6.5. And what did they find? Little benefit of intensive control. Accord, there was increased mortality, 250 patients died. So they had to discontinue the trial. So what is the big message for cardiovascular disease from all these studies? That good glycemic control does not prevent heart attack. You could still die of a heart attack with an HbA1c of 6.5. That is the big message that we know. So diabetes is not only about sugar. Blood sugar is just one aspect of it. And if you ask me, blood sugar is the one which causes the microvascular complications. The macrovascular is different. So when you're treating type 2 diabetes, you should treat the hyperglycemia. You should have a good glycemic control, which would prevent your microvascular complication. But you have to look at the dysmetabolic syndrome, which is the main thing, which everybody forgets. In their attempt to, sell drugs, nobody talks about this. They only talk of glycemia, glycemic variability, postprandial hyperglycemia. Come on, yaar. Look at this. Dysmetabolic is insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, and a procoagulant state. Diabetes is an atherogenic state. You get premature atherosclerosis. So when you are treating a diabetic, what do you need to do? You need to obviously have a combination, and that's the topic. That with SGLT2, what will you combine? You want a good glycemic control, every molecule will give you a good glycemic control, the way you use it. Whether it is sulfonylurea, insulin, or DPP4, whatever. Next and most important, one of the important aspects is you want to preserve beta cells, which will give durable glycemic control. Why does diabetes progress? Because of apoptosis of the beta cells. This is UK PDA study which says that at the time of diagnosis, more than 50% of beta cells are already gone. These are about 10 studies which show use of sulfonylurea. See, initially there is a good decline of HbA1c in the first year. And then you find it is going up. This is showing the progression of the disease. And why is that progression of the disease? Because the beta cells are dying, which tells you that sulfonylureas cannot preserve the beta cell. These are 8 studies using glitazones. Look, initially down, and then there is a steady HbA1c maintained for about 5 years. What does that tell you? That probably these drugs are preserving the beta cells. So why does beta cell apoptosis really take place? Most important is lipotoxicity. Of course, hyperglycemia and glucotoxicity also does. Insulin resistance will promote both these. plus have a direct effect on apoptosis. So, what is the effect of a glutathione? How does it preserve the beta cell? Forget all that. Just what is in the yellow. There is a mobilization of toxic lipid metabolites out of the beta cell. And that is what leads to the preservation of the beta cell. And that is the importance of using a glutathione. So that's as far as preservation of beta cells, we only have pioglitazone. GLP-1 analogs have been shown to have some preservative and even regenerative effect on beta cells, but still in experimental stage. Next is treating insulin resistance. We are an insulin resistant population. 83% of type 2 diabetics are insulin resistant, and this is highest in Asian Indians. All studies have shown that insulin resistance has been demonstrated in Indians even during adolescence. Professor Yagnik, who was here, has shown this, that it starts in intrauterine life. So that is what the problem is. These are the two major studies which have shown, Helsinki and Verona diabetes study, that insulin resistance is an independent risk factor for the prediction of cardiovascular disease. So what are the clinical manifestations of insulin resistance? Insulin resistance will cause glucotoxicity, lipotoxicity, etc. All this. Let's look at this, the clinical consequences. You have diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, peripheral vascular disease, stroke, PCOS, NAFLD, and NASH. This is what insulin resistance causes. And unfortunately, we as doctors are not addressing insulin resistance the way we should. This is the ticking clock hypothesis, the Nurses' Health study. I won't go into the details. But what this showed was that the elevated cardiovascular risk began 15 years before the onset of diabetes. So what are we talking? We are just being sugar controller without looking at the basic pathophysiology. Now, is there evidence that insulin resistance treatment will help? Yes. What will treat insulin resistance? Diet, exercise, weight loss will treat insulin resistance non-pharmacologically. Pharmacologically, metformin and pioglitazone. And these are the diabetes prevention studies which have done good results. Pharmacologically, all these studies using glutazones have done, but the IRIS study is very important. I'll show you that. What was this IRIS study? This was a study in non-diabetic patients. Non-diabetic patients who had a TIA or a stroke and who had insulin resistance. They checked their HOMA. For HOMA, you do a fasting sugar and a fasting insulin level, and there is a formula to calculate. And if the HOMA was more than 3, they labeled them as insulin resistance and put them on pioglitazone, 15 to 45 milligrams, and placebo, followed them up for 5 years. What did they find? Recurrent stroke reduced by 24%. These patients were already had a stroke. But if you look at the proactive study, stroke reduced by 47%, and that was the reason why this study was done. So recurrent stroke reduction is 24%, myocardial infarction reduced by 24%, new onset of diabetes by 52%. So this is the first time that a therapy directed purely at insulin resistance, there is no diabetes involved, gave you this kind of benefit. That is the importance of it. But look at it. This was the ad hoc analysis of the IRIS. About 2,885 patients who had pre-diabetes. They were not diabetic, but they're pre-diabetic. Either an impaired fasting glucose, impaired postprandial, or a HbA1c in the pre-diabetic range. And what did they find? Their combined stroke, myocardial infarction reduced by 40%. Stroke itself by 33%. Acute coronary syndrome by 52%. New onset of diabetes by 80%. Now, that is the benefit you get by treating insulin resistance, which no molecule, nothing, you can get your HbA1c to 5 and nothing will happen, you will die of hypoglycemia, nothing else. So this is the importance. So when you talk of treating insulin resistance, the only molecules we have is a pioglitazone and metformin. Should not cause hypoglycemia, I have already discussed, all except insulin and sulfonylureas. Should not cause weight gain. SGLT2 will cause a weight loss about 2 to 3 kilos. GLP-1 again 2 to 3 kilos, that's it. Metformin and DPP-4 inhibitors are weight neutral and pioglitazone is weight positive. It should be renoprotective, SGLT2 across the board. All the molecules have shown consistent and impressive renal benefits in both primary and secondary prevention. What do you mean by primary? You could be on an SGLT2 and prevent a nephropathy taking place. You could have a patient who already has a nephropathy, it could be reversed with the use of an SGLT2. So that is where this was. So when you talk of renoprotection, SGLT2. Cardiovascular benefits, UKPD has shown metformin, and that was the reason why metformin was really approved in the US. So SGLT2 are a good option in patients that are not meeting their glycemic control. I have already discussed about SGLT2. Which anti-atherogenic properties and cardioprotective effect. You have the proactive study, the Chicago study, the periscope study, the IRIS study. The IRIS which I just discussed with you. Several meta-analysis and many observational studies. This is a comment by Robert Ryder and Ralph DiFranzo that pioglitazone is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, and plenty of evidence of cardiovascular benefit. Other drugs which have shown cardiovascular benefit is the GLP-1 liraglutide and semaglutide. So what is the strategy? What will you combine with an SGLT2? Macrovascular damage starts many years before the onset of diabetes. Many years. Insulin resistance and its complication and beta cell preservation have to be adequately addressed for positive long-term outcomes. If insulin resistance is treated right from day one, we will see lesser macrovascular complications. Metformin and pio most durable, less weight gain when sulfonylurea is not in place. But if you add an SGLT2 to a metformin and a pio, it's a deadly unbeatable combination. The weight gain of pio is neutralized by weight loss of SGLT2. The fluid retention of pio is reduced by SGLT2. Fantastic combination. So metformin pio gives you the best result when endogenous insulin is present. What does that tell you? That you have to start early. You don't start pio after 10 years of diabetes when all his beta cells are thakke gaye hai sir. Right from day one, the day he comes to you, unless there is a contraindication, start him on a metformin pio and SGLT2. When endogenous insulin, that means early in the history of diabetes, is early use, intelligent use. So what would be the ideal algorithm? What are you aiming at? You want to reduce peripheral insulin resistance, you want to preserve the beta cells, and you want to prevent diabetic complications, and you don't want hypoglycemia. So these are the molecules which you have. Metformin, glitazone, SGLT2 would be on the top of the list, right from day one. And if they don't work, you could add a DPP-4 or a GLP-1. GLP-1 is a very heavy on the pocket. I would go with DPP-4. If that does not work, if still your sugars are not controlled, you may need a slight push with a sulfonylurea. So these are the sulfonylureas you have, and among them I would say a modified release glycoside would be the best, because chances of hypoglycemia is minimum with them. If the patient has only a postprandial hyperglycemia, you would use add an alpha glucosidase inhibitor. And if after doing all this, his sugars are still not controlled, that is when you go for insulin. This would be the algorithm for treatment, and the combination with SGLT2 would be a metformin and glitazone right from day one. Thank you very much, ladies and gentlemen.